Our first speaker is Dr. Richard Silver. Many of you already know Dr. Silver, and some of you, he is your physician or your counselor, or you've heard about the services at MUSC through him. We're always excited to have Dr. Silver share information about what's going on at MUSC. Personally, I find it very inspiring. Dr. Silver is a distinguished professor in rheumatology and immunology at the College of Medicine at MUSC, and he's the co-director of the Scleroderma Center, the former director of the Rheumatology and Immunology Division. And you're going to see in his PowerPoint presentation, he has some additional roles coming up. So he's going to give us some updates about research, education, and patient care at MUSC.
Well, thank you, Karen, and thank you all for tuning in on this Saturday afternoon. I don't know what it's like where you live, but it's a beautiful day here in Charleston. It would have been a nice day to have an in-person meeting, but perhaps next year. And I suspect next year, if we're in person, we'll still have a hybrid format because I'm really impressed that we have people from as far away as Oregon, New York, Florida, and elsewhere. So thank you all for tuning in. And it's really a privilege for me to make this presentation every year because it gives me an opportunity as I prepare the presentation to look back and see what we're doing. And sometimes it's not obvious with our day-to-day work. We're our nose to the grindstone, and we sometimes lose sight of all the other things that are going on. So this is a good opportunity for me. So acknowledgements often come at the end of a presentation, but I think some of the people I would like to acknowledge are shown here and at the top of the presentation. Of course, Amy Parrish, who inspires us every year to have this program and inspires us every day to work towards finding a cure for scleroderma. And then our leaders, Susan and Karen, you've heard from, and Francis Parrish, who is working behind the scenes. We couldn't do this without your efforts and expertise. And as mentioned, our support group leaders across South Carolina. We need to get the Columbia group going. I would love to have a group up in the Myrtle Beach area as well, but with virtual meetings, it makes it easier for people throughout the state to attend, even if they don't live in a particular vicinity. So thanks to all of these people for all of their volunteer work. Also, as Karen mentioned, we have a new logo, a new name for the foundation. We're under new leadership with Mary Wheatley as our new CEO, and a new strategic plan. So a lot of exciting things coming down the pike from the national level. And I think will inspire us to really move to the next level, while at the same time retaining the core values that the foundation has had over many years. And then I want to shout out to some of the people who do the work here at MUSC in terms of clinical trials. Megan, Brittany, Jonathan, Lori Ann, these are all really dedicated individuals who help us day to day in managing our clinical trials and really care deeply about our patients. So this is a year in review pertaining to MUSC and what's going on in our scleroderma center. We have, like any academic medical center, a tripartite mission that includes patient care, research, and education. And the sweet spot in the middle is where I like to be, where I'm providing patient care, maybe teaching a resident or a fellow about scleroderma, and conducting clinical research at the same time. And all of our faculty members here at MUSC who are engaged in scleroderma patient care and research are also providing education to the next generation of clinicians as well as scientists. So we'll take this one by one. This is in terms of patient care. I'm fortunate to work with a wonderful team in our division of rheumatology and immunology. The top row, you probably recognize some of these people if you're a patient here at MUSC. Dr. Smith, Dr. Hant, Dr. Baker Frost, Dr. Ward, and Dr. Kate Silver, who does pediatric and adult rheumatology. So these are the people who are really providing day-to-day terrific care for our patients with scleroderma. And we couldn't provide the excellent care without their compassion and their expertise. But as the saying goes, it takes a village. So we have subspecialists in other areas who, because we see many patients here at MUSC with scleroderma, these individuals have developed their own expertise in their subspecialties. And we're very fortunate to have pulmonologists, cardiologists, gastroenterologists, even ophthalmologists who have expertise in interstitial lung disease, pulmonary hypertension, all of the GI manifestations, all the cardiac complications and dry eye syndrome, as well as other subspecialists here at MUSC. So again, it's one of the attractions, I think, for patients who can come to MUSC and receive expert care across multiple different disciplines. In terms of patient care, we stay very busy. It seems to be increasing every year. And looking through our electronic medical record, we had about 1,000 scleroderma return visits this past year, and we saw over 100, actually 120 new patients to us in the past year. And we've maintained a top 20 ranking in the US News and World Report rankings for scleroderma or rheumatology centers in the US. In terms of education, it's been a busy year. This slide illustrates the locations of the rheumatology fellows who have completed their training at MUSC over nearly 5 decades. And you can see that we do have people as far flung as Washington and Oregon, as well as the Northeast, and a few even in the Midwest, including North Dakota. So this past year, we graduated 3 fellows, and they're highlighted in red. So Dr. Sonia Savani, who's a pediatric and adult rheumatologist, took a position at the University of South Alabama in Mobile. Dr. Samantha Minkin took a position at Vanderbilt in Nashville. And Dr. Sarah Compton joined one of our former fellows, Dr. David Caldwell, in a private practice in Hickory, North Carolina. So we feel like we're helping the cause nationally by training our fellows in caring for patients with scleroderma and then sending some of them away to provide care in their new locations. The other aspects of education are shown on this slide, which is a little bit busy, but summarizes most of the major education activities that we do. Of course, we do the annual Amy Parish Patient Education Program. This is the 12th year we've done it. And twice in those 12 years, we have won the National Award for Patient Education from the foundation. This past year, one of our trainees earned his PhD. This is, I should say now, Dr. Charles Reese, who is staying on as a postdoctoral fellow and continuing his research in scleroderma. So we're very proud of this accomplishment for Charlie. Our faculty members are engaged in 2 training grants that are funded by the NIH. Dr. Fagali Bostwick is involved with both of them. She leads the pulmonology training grant. and she co-leads the Inflammation and Fibrosis grant within the Division of Rheumatology. And together, these two training grants provide funding and resources to mentor graduate students, including students who are pursuing their MD and their PhD degrees. And these will be the future of research in scleroderma and other related fields. Over the past year, our internal medicine residents had the opportunity to rotate on rheumatology, and 70 internal medicine residents did so in the past year. For many of them, this is the first time they actually get to see, listen to, and examine a patient with scleroderma. And some of them get intrigued. Some of them choose to go into rheumatology as a chosen field. So we think this is an important part of our education activities. In addition, medical students, usually fourth-year medical students, have the opportunity to rotate on rheumatology. And again, some of them will be inspired to go on to become rheumatologists. Our fellowship program is led by Dr. Hant, has continued to do an outstanding job. So we graduated 3 fellows last year, and we accepted 3 outstanding applicants who will be joining us in July. And speaking of Dr. Hant, who's shown in the picture next to me at the bottom, she was promoted to full professor just a few months ago, and a great accomplishment for her. And we're very proud and very thankful for the work that she does every day for our fellowship program. So in terms of research and education, so I'll just quickly go through what's going on in some of the labs in our division. If you've been attending our programs in the past, you've met Paula Ramos, one of our terrific young researchers. And I've highlighted that she not only does research, but she's also teaching. So my Venn diagram shows both of these activities. So she teaches by mentoring other faculty members, as well as students, medical students and graduate students. She's in preparing a manuscript that is looking at differences in the gene expression of African Americans with scleroderma compared to healthy African Americans and Caucasians. And this, I think, will be a very important contribution to the medical literature. And currently, she is looking at conducting research on the genes that might be dysregulated, leading to the abnormal immunological aspects of scleroderma. And a shout out to the National Scleroderma Foundation for funding that research. Of course, our rock star is Dr. Fagali Bostwick, and she's shown here with all of her researchers proudly wearing the mask provided by the South Carolina chapter of the Scleroderma Foundation. I was telling somebody that in my tenure as division director, I count in terms of major accomplishments, the recruitment of Gary Gilkison and then the recruitment of Carol Fagali Bostwick to our faculty among my highest achievements as a division director. As you know, Carol also serves as vice chair of the board of directors of the National Scleroderma Foundation. She has boundless energy, enthusiasm, and passion for our disease and our patients. Just in the past year, she published 11 new research papers, was awarded 2 new research grants, and you can see a number of different honors at the national level. She was locally here at the Medical University, given the title of Distinguished University Professor and continues to receive a number of accolades here at the Medical University of South Carolina. And Carol serves not only on local foundations and activities, but also at the national and truly at the international level. So we're very grateful for Carol and all of that she is accomplishing. And I just found this out yesterday. This is why I had to modify my slides this morning. Yesterday, February 11th, was the UN's International Women and Girls in STEM Day, science, technology, engineering, and mathematics. And we should celebrate that, I think, every day. And there is no better example of someone who promotes women in science and in medicine than Carol. So we hope she will continue to do this for many, many years. So not only is she conducting cutting edge research, but she really is inspiring the next generation of women and men in medicine and science. And one of those people, this was a nice segue, you met her earlier as we were getting started, Dr. Deanna Baker Frost, another very important recruit to our faculty several years ago. And you'll hear from Deanna a little bit later in the program, but she this past year had a very nice publication looking at how an estrogen molecule, estradiol, plays a role in fibrosis of the skin. And she is pursuing this research under the mentorship of Carol Fagali-Bostwick. And I'm really proud to announce that Deanna Baker Frost will receive one of the new investigator grants from the National Scleroderma Foundation. This is a 3-year grant that will help fund her research on the role of estradiol in systemic sclerosis. So kudos to Dr. Baker Frost. Dr. Hoffman is shown here in the center, and that he also is conducting important research to develop a new method of treating scleroderma and other forms of fibrosis. Again, he is not only conducting research, but he is providing education or mentorship. So that's Charlie Reese, or Dr. Charlie Reese now on the right, and Dr. Kupaswamy on the left, who's a cardiology faculty member here at MUSC, who is collaborating with Dr. Hoffman looking at fibrosis of the heart. Also a very important topic, not only for people with scleroderma, but people with a variety of different cardiac diseases that result in fibrosis and heart failure. And this is my group. Some of these people have left, but one received her PhD and continues to work in MUSC. One has returned to Japan for a faculty position, but we're working to develop a new molecule that might one day become a pharmacologic treatment for fibrosis, including fibrosis in scleroderma. And we received an award from the NIH. We also have an industry-sponsored award for our independent research on lung fibroblasts. So Dr. Bogatkevich and her team is making great progress here. We also have a core center for clinical research, or a CCCR. This is an NIH-funded grant that allows us to develop a core facility, in this case to collect clinical and laboratory information on patients with scleroderma and lupus, with an emphasis on those two diseases, but also an emphasis on African Americans who may be impacted more severely by these autoimmune connective tissue diseases. This Core Center is led by Dr. Gilkison and co-directed by Dr. Oates and myself. And we've just gone back in for a resubmission, and will be under new leadership. Dr. Oates will move to the top. He'll be the new director of the CCCR core. And I want to thank you in advance, all of those people with scleroderma patients who have volunteered to give clinical information and clinical samples for this important core, which can be accessed by investigators from around the country or even around the world with the proper oversight. And of course, all of the information we would provide would be completely de-identified and only with the consent of the subject. But to have information on more than 300 scleroderma patients is a tremendous resource to the research community. And we continue to recruit new subjects for this core. There's another registry that we're very much involved with, and this is the CONQUER registry, which is funded by the Scleroderma Research Foundation and led here at MUSC by Dr. Hant. And so this is a registry that is still recruiting individuals. They must be over 18 years of age. They must fulfill the classification criteria for scleroderma. And this particular registry is focused on people with early disease, less than 5 years from the onset of their first non-Raynaud's symptom. And the way the CONQUER registry works, starting at the top left, during a regular patient visit and after receiving or giving informed consent, blood, urine, sometimes skin samples are obtained and de-identified and stored in a biorepository at UT Houston. The data, clinical data, is stored at a coordinating center at University of Utah. And then individual research institutions can apply for this, again, de-identified data for their particular research if it's been approved by an executive committee. So again, thank you to everyone who may be participating with Dr. Hant in the CONQUER registry. So that brings us to clinical trials, and I just want to say a few words about clinical trials in scleroderma. These are not easy to do. For many years, there was very little interest by the pharmaceutical industry in clinical trials for this disease, which, as you know, is an orphan or rare disease. And so in the last 5 to 10 years, there's been a huge increase in interest by big pharma in terms of doing these trials. But many of them have been negative trials or difficult to complete for a variety of different reasons. Most recently, the COVID pandemic, which has seriously impacted our ability to do clinical trials. You may know that there are 2 drugs that have been FDA approved for the treatment of interstitial lung disease or lung fibrosis in people with scleroderma, those drugs being Ofev and Actemra. So we are making progress. This is, and so pharmaceutical companies are still very much interested in studying a disease like scleroderma. So once we get through the pandemic, I think we'll see an even greater upsurge of interest by big pharma. So the studies that we've been engaged in here at MUSC are shown through these bullet points. And I'll go through them briefly in the next few slides. But you can see SLS3, Scleroderma Lung Study 3, enrollment has been closed. And the Cadman study enrollment has been closed. And both of these studies were very seriously impacted by the COVID pandemic. And many clinical sites were unable to recruit patients to be enrolled in this study. We were the exception, and I'll show you that in a moment. We have one trial that is currently enrolling, and then we have one trial that is really almost set to get started in the next month or so. So let's start with scleroderma lung study 3. This was a clinical trial that was designed to determine if you were to add an antifibrotic drug to an immunosuppressive drug at the beginning, would that be better than an immunosuppressive drug alone? So the antifibrotic drug is called pirfenidone. Its trade name is Esbriet, and it is already FDA approved for treating people with idiopathic pulmonary fibrosis, or IPF. The immunosuppressive drug is mycophenolate or Cellcept. Many of you are familiar with this drug because it's used as an immunosuppressive therapy for many patients with scleroderma. So the hypothesis of this study was that if you added an antifibrotic drug to the Cellcept at the beginning of the disease, you would have a better outcome in terms of lung function and skin score than if you just use the immunosuppressive drug alone. So the study was designed to enroll 75 patients in each of 2 arms. So 75 patients would get Cellcept alone, and another 75 patients would get pirfenidone and Cellcept. And they would be treated and followed for 18 months. And then we would determine if the combination therapy was better than the single drug alone. This trial was seriously impacted, again, by the COVID pandemic, leading the sponsor to end the study, in the recruitment. Only 51 subjects were enrolled nationally, so 1/3 of what we hoped to enroll for the entire study. And I'm very proud to say that 8 of the 51 were enrolled from MUSC. 6 have completed, 2 will complete, the other 2 will complete the trial later this month. So all 8 of our subjects will complete the trial, and we will do the best we can given the loss of statistical power by having only 1/3 of the number of subjects that we had anticipated. But we may learn from this study, hopefully we'll learn that if combination therapy is better than individual therapy. And I wanna thank the clinical coordinators again, and special thanks to the patients who were enrolled in SLS3. Another study that was ongoing until last month was this Cadman study, KD 025209. And this is an interesting study looking at a drug called belumosudil, which has an effect on T lymphocytes to decrease the overall immunologic activity, or to restore more normal balance in terms of T cell immune regulation. And this drug actually, while this study was underway for scleroderma, was granted FDA approval for another indication called chronic graft versus host disease. So GVHD is a condition that occurs in some people who get a bone marrow transplant, or they're mostly a bone marrow transplant. And it has some features of scleroderma with inflammation and fibrosis, and even sometimes the development of autoimmunity. So a very promising drug for a disease like scleroderma, but again, mostly due to the pandemic, and also due to the fact that Cadman, the sponsor of the study, was bought by another pharmaceutical company. This study has been closed to enrollment. And I highlighted the enrollment there on the right of the screen. So in terms of the number of people randomized, that number should be 37 at the bottom. And here at MUSC, that number 6 should be 7. So we enrolled 7 out of the 36 patients internationally in this clinical trial. So we will continue to follow those patients who are in the study and hope that although we have a much smaller number of patients than we wanted, hope that we can still learn whether this drug might prove to be effective for our patients with scleroderma. So we must, again, stay tuned. We have one clinical trial that we're currently enrolling for, and this is called the BRAVO study. And this is looking at a drug called brentuximab, which is a very interesting drug. It's a drug that is designed to find certain T lymphocytes that we think are involved in the disease. And the drug, the molecule carries with it something that will be internalized to that T cell only and kill the cell. It will not attach to other immune cells or other types of blood cells, will not cause the types of side effects that we would expect with a more general suppression of the immune system. And this is a very early study, meaning we're trying to find out what dose would be most best tolerated. And once this study is completed, we hope that we will go forward with a larger study looking at one particular dose, the chosen dose, to study its potential effect as well as its safety. So patients 18 to 70 years of age, early within the first 5 years of disease, and a skin score between 15 and 45, and on stable background immunosuppressive therapy would be potentially eligible for this study. So if this is something that you think you might be interested in, please contact me and we can talk about it. The study that is getting ready to start here at MUSC, it's already started at several sites already, is an interesting study of a medicine that will block something called the LPAR1 receptor. And it's been shown by investigators, including Carol Fagali-Bostwick, that this receptor on the surface of certain cells called LPAR1 receptor is involved in inflammation, in tissue damage, and ultimately in fibrosis. And so the hypothesis of this study is to ask the question whether blocking that receptor and blocking the signals that would occur otherwise might improve the amount of inflammation and fibrosis in scleroderma. So this is an oral drug. It's going to be given once a day, twice a day, or a placebo. So people will be randomly assigned to get the medicine or a placebo for 52 weeks. And those people who are enrolled in the study and complete the 52-week study, which is placebo controlled, would then enter an open label study where they would get the medication for the next 52 weeks. So we're going to be recruiting, since the other studies are closed except for the BRAVO study, we will be recruiting actively to enroll patients for this clinical trial. And this is being conducted not just in the United States, but around the world. And the goal is to recruit 300 patients for this clinical trial. So we hope that MUSC can do our job to help complete that enrollment. So just want to close with some words about our Scleroderma Center endowment. We have a goal of raising $3 million to endow our center. The money that is being raised for this endowment will be invested in perpetuity, and only the interest will spin off of it, and that will be used to support our center in terms of our education and our research missions. And my goal is $3 million. The payout each year would be about $120,000, which would be used to support our clinical researchers and our basic researchers as they conduct their research and education. So in this center is my next door office mate, Nat Howe. He's a development officer for the Department of Medicine. And as Karen alluded to, one of my other roles is to serve as vice chair for development in the Department of Medicine here at MUSC. So we are grateful to all of our donors in the past, over many years, and in the past year, including the Rowland family, who made a generous donation to help support our research. We also received very generous gifts from families in Cincinnati, Bowling Green, Naples, Florida, and throughout South Carolina and North Carolina. So we're very grateful to all of our donors. And if you're interested in learning more about this, either as a gift or a planned gift for the future, please contact me, and Nat and I will be happy to talk with you about that. And finally, just to close, I want to thank all of you and all of our patients for entrusting your care to us and for participating so generously in all of the things we may ask you to do, which could be giving us a skin biopsy, blood, DNA, urine, patient outcome reported forms to be completed, and participating in clinical trials. We could not do this without you, and we're very, very, very grateful for your participation and your confidence in us by entrusting your care to us. So thank you all very much. And that is the end of my slideshow. So I will stop at this point and turn it back to Karen.
Well, that was fantastic. And I always get so excited when I see information about research studies. And I had a question going along, but then Sarah Budd, one of our Charleston support group leaders, put that very question in the chat box. So I thought I would go ahead and ask that of you. We were going to have Francis do it, but since I'm talking, Francis, I'll go for it. So Sarah asked, why do the majority of studies want diffuse patients with less than 5 years of disease? And I thought that was my question too, because I bet that's confusing for patients, because old timers like us were thinking, I want to be in this study, but we're kind of not really eligible.
Right. So it's a very good question, and I'll try and answer it as best as I can. So we focus more on diffuse disease than on limited disease because patients with diffuse disease have more extensive skin involvement, and the readout for these clinical trials might be the skin score. I made a presentation to the national group. Patty, thank you again for being in that, where I demonstrated how the skin score is performed. And when you have very limited disease, the skin score is very low, and there's a lot of variability, or enough variability, in how you do the score from day to day or one person to another, that it's not really possible to detect a change. So that's the main reason why diffuse is selected over limited. Now, the question, well, why early disease and not, somebody who's had the disease 10, 15 years or longer, relates to an observation that was made maybe 35, 40 years ago in a trial of a drug called penicillamine, where there was a placebo group. And that trial showed that there was no difference between penicillamine and placebo. I think it was over 18 months, might have been 24 months. And the fact that the people on the placebo, their skin score went down, their skin softened. And so it's felt like if you, so that's another confounder for doing clinical trials. You wouldn't have a placebo group per se, you'd have somebody on background therapy, but then they would be taking a placebo for the drug under study. And most of the change in the skin, so we're looking for a change, getting better or getting worse. Most of those changes occur in the first 5 years. And so it's really somewhat arbitrary and based on sort of group statistics, whereas an individual might still have the opportunity for their skin to get better or get worse after 5 years. I think it speaks to the fact, Sarah and Karen, that we need what's lacking is a biomarker, a blood test, a biopsy result, something that would tell us that the disease is active. And so somebody who might have 3 years of disease might be inactive by that time, or somebody with 7 or 10 years of disease, it could still be active. And we could enrich our group of patients for a clinical trial if we had such a biomarker. And many people around the country, around the world, are doing research trying to discover just such a marker. And some of these registries, like Dr. Hant's involvement in the Conquer registry, that could be probably one of the most important outcomes of that sort of registry. So that is the main reason.
And I think, and I can imagine, like you say, it kind of muddies the water, so it's hard to see a drug's effect. And I know for personally, as I've aged over 30 years with scleroderma, some of the changes I'm having are part of my aging. And it's hard to tease out some of that.
Yes. So
there was another question about progress. Well, actually, I'm going to look at the time. So we got about a minute. There was some progress a question about progress on Dr. Carroll's study of the E4 peptides to reverse fibrosis. Do we have any updates about that?
Is Carol on? Can we unmute?
She is around here. Yeah.
I am.
Carol, I really gave you a great build up, but you'll have to talk about Oates about the raise, okay?
That was very generous. Thank you. Actually, I was teary-eyed as I was listening to you talk. Thank you very much. So our peptide is moving forward. The company that licensed it has been doing a lot of preclinical testing and assessment of things like stability, do we need to use plastic or glass vials? Does it stick to it? The kind of things that you need to go through at the end before you actually start before you submit your IND application, start the phase 1 trial. So we're still moving forward. It's just taken a little longer than we anticipated. There's been a change at the company of people who are involved. But also, when you do preclinical testing of drugs, there are always things that come up that you need to explain or look into further that take you in a slightly different path. But the good news is we're still going forward. It's just we've had to do a little more work and it's taken a little longer.
Kind of like a lot of things, right? The past couple of years. what a chapter to put in our books.
Yes.
So I want to mention in the chat box, we have a couple questions that are about scleroderma in general. I'm going to save those to the end because they're talking about GI questions, maybe something changes about changing medication. So we'll wait till the end with that. So what I'm going to do is thank you, Dr. Silver. That was great.